Thank you very much indeed, Nicole. Yes, there is a mistake in the program. It's got that I come from the UK. I do not come from the UK. I come from Ireland. We had a war with Britain back in the 1920s, and we kicked them out of our country, at least out of most of it. So I'm Irish. I want to sort of continue many of the points which, in fact, the first speaker covered. But like him, I will have to be very quick because we don't have a lot of time. Those are the sort of areas that I want to briefly cover with you in the next 15 minutes or so. And I hope that the chairman will give me a note when we're getting a bit near the end. So first of all, the genetics, and this really links in, I think, with a lot of what Professor Ferrier was saying, that if we actually look at the genetics of patients with treatment-resistant depression, it's very clear that there are a number of polymorphic forms of the pro-inflammatory mediators which appear to be linked very much to the patient with treatment-resistant depression. And also, if one looks at some of the growth factors, the neurotrophic factors, again, there's a suggestion of an abnormality in the gene expression of many of those growth factors. So we have, in other words, a combination of two aspects which, in the long run, could possibly lead to neuronal abnormalities, which ultimately, of course, will be associated with treatment resistance. On the one hand, a chronic low-grade inflammation, and secondly, changes actually in the synthesis of neurotrophic factors and the expression of neurotrophic factors, thereby leading to a reduction in neuronal repair. If I want to concentrate particularly on the inflammatory side, because I think this has tended to be ignored in the past when considering both depression and particularly resistant depression. First of all, here we're dealing with, when we think of inflammation, we normally think of infection. We normally think of a dramatic release of pro-inflammatory cytokines from macrophages, microglia, and so on and so forth. And that undoubtedly occurs, but in the case of chronic low-grade inflammation, which we're talking about, we're not talking about these dramatic increases. We're talking about a slow increase in relatively small increases in concentration of pro-inflammatory cytokines which are constant. And these affect not only the periphery, but particularly affect the brain. And there's now some evidence of a leaky blood-brain barrier in depression, which allows these very large, bulky molecules to enter the brain. But also there's some very interesting research going on at present suggesting that the gut microorganisms may also play a role in terms of brain function, and certainly in terms of brain pathology. So pro-inflammatory cytokines penetrate the brain, and as a consequence of penetrating the brain and being present in chronically within the brain, it has consequences both in terms of cognition and in terms of behavior. And this is due to the fact that the pro-inflammatory cytokines contribute to the activation of the hypothalamic pituitary adrenal axis, as we've heard from Professor Ferrier. In addition to that, the pro-inflammatory cytokines increase the actual synthesis of endogenous neurotoxins, such as quinolinic acid, which I'll talk more about later, which activate the glutamate system, and this causes premature apoptosis. In addition to that, of course, the pro-inflammatory cytokines and other mediators have a profound effect upon monoaminergic function in the brain. So without going into any sort of detailed immunology, this cartoon just sort of summarizes the relationship between the peripheral between the peripheral immune system producing pro- and anti-inflammatory cytokines, and in depression there's an imbalance between these, the balance going preferentially towards the pro-inflammatory cytokines. And these, in fact, influence the brain, but not only do they influence the brain, but also there is another pathway going from the brain back to the periphery via the sympathetic and parasympathetic nervous system, because if one looks at immune cells contain most of the neurotransmitter receptors, as well as endocrine and immune receptors. So there's a complete crosstalk between the brain and the periphery. In the brain, the astrocytes, the microglia, and indeed the neurons also can produce and do produce cytokines of various sorts, including pro-inflammatory cytokines. So we have a complete interaction between brain, periphery, and brain. So there is this very important crosstalk involving the pro-inflammatory cytokines. In addition to that, of course, the opioids are very much involved in cellular immunity and affecting cellular immunity, which is an important part, again, of major depression. And also the secondary effect of the increase in pro-inflammatory cytokines is to increase the production of other mediators of inflammation, such as prostaglandin E2 and nitric oxide. And so you can see you have a very rich mix in the brain of inflammatory mediators as a consequence of depression. The evidence in favor, of course, is now very telling. There's a whole number of studies now showing an increase in the cytokines, an increase in acute phase proteins, increase in the inflammatory chemokines, soluble receptors, and indeed prostaglandins and so on and so forth. So all of these increase in depression, and there is some evidence that the increase is further accentuated in patients with treatment-resistant depression. I'm not going to talk more about this. Professor Ferrier has already covered this, but cortisol plays a very, very important part, not only, of course, in affecting the intermediate metabolism of fat, glucose, and so forth, therefore contributing very much to the metabolic changes which we see in major depression, treatment-resistant depression, but particularly in inhibiting the synthesis of neurotrophic factors. So this is an additional effect on brain repair mechanisms which we get with treatment-resistant depression and severe depression. So this just sort of summarizes some of the main points. Stress and depression activates the HPA axis, which leads to increased apoptosis. It also, as we've already heard, has a profound effect on serotonin. I'll come back to this later. There is a consequence of that in terms of the production of beta amyloid. And also it activates macrophages, microglia, and so forth, leading to chronic low-grade inflammation. All this is accentuated in patients with treatment-resistant depression. This cartoon just sort of summarizes the pathway going from the vulnerability factors, which we heard about in the previous lecture, increased apoptosis, leading to failure to cope with the novel situations, reduced memory and learning, damage to emotional circuits, and then leading to depression. We're talking, in other words, as a sort of a subtle neurodegenerative type condition following long-term chronic depression, which is accentuated in patients with treatment-resistant depression. So why do neurons die prematurely in these cases in depression, and particularly in treatment-resistant depression? Well, one of the main reasons, we think, is due to the hyperactivity of the glutamate system. And this is caused partly by the action of the pro-inflammatory cytokines, which block the removal of glutamate from the synaptic cleft, therefore allowing the further stimulation of the excitatory amino acid receptors on neurons, and thereby increasing calcium influx, and as a consequence of that, death of the actual neuron. Also, the reduction in neurotrophic and neurotrophin synthesis as a consequence of the rise in glucocorticoids. So if we look again in a little bit more detail, there are a whole number of other changes which occur in treatment-resistant depression which link treatment-resistant depression to an increase in neurodegeneration. And this just summarizes some of the possible trigger factors leading to a decrease in brain-derived neurotrophic factor, to insulin growth factor, to VEGF, and to an increase in pro-inflammatory cytokines. Now, what we do know, of course, in the early stages is effective treatment will reduce some of these changes, but by no means all. And, of course, once they become established and produce brain damage, this is, in fact, where, in fact, it becomes very, very difficult. And what is the evidence for that? Well, we've known for a very long time that in major depression there is indeed an increase in neurodegeneration affecting the hippocampus, the prefrontal cortex, and indeed the amygdala. And that the more prolonged the actual period of depression, and particularly resistant depression, the more likely the neurodegenerative changes become manifest. And the question arises, well, what causes these neurodegenerative changes? Are there specific factors which actually are produced in patients with major depression? And this summarizes some of the pathways which appear to be enhanced in patients with depression, the so-called kynurenine quinolinic acid pathway, which we discussed in a session yesterday of the WPA immunology section, leading to quinolinic acid, which actually activates the N-methyl-D-aspartate glutamate receptors. There's also an increase in nitric oxide, leading to increased lipid peroxidation. There's an increase in glucocorticoids, which have a profound effect upon neuronal repair, and also there's an increase in the synthesis of prostaglandin E2, which has a profound effect, particularly upon some neurotransmitter processes in the brain. So all of these toxic pathways, to some extent, really are very, very important in depression. I'm not going to go into all of the biochemistry of this, excepting just to bring to your attention some of the work which has been done. It started in a group I was associated with in the University of Maastricht back in 2003, showing indeed that in depression there's an increase in the breakdown of tryptophan away from serotonin down to the synthesis of this neurotoxin quinolinic acid, causing neurodegeneration. Conversely, the neuroprotective pathway is decreased in patients with major depression. And so we do have a biochemical mechanism behind this, and one can actually show this in patients by measuring the ratio, what we call the neuroprotective ratio, between the quinolinic acid, which is the neuroprotective component, and kynurenine, which is the precursor. And basically what you'll notice in comparison to the controls, there's a marked decrease in the neuroprotective ratio in the depressed patient before treatment. After 8 weeks of treatment, in fact, it doesn't change appreciably, even though the HAM-D scores decreases. And this suggests, in other words, that when we're dealing with chronic depression, whatever antidepressants are doing are not necessarily providing a full neuroprotection. We subdivided the group into those that were on the first episode of major depression, and there was a slight improvement after antidepressant treatment in the neuroprotective ratio. So it does mean one has to start drug treatment vigorously and continuously, as we heard from our previous speaker. And this just gives you some idea of a post-mortem study of the brain of suicides, and this is staining microglia and also under high power for quinolinic acid. So you can actually show there's an accumulation of quinolinic acid in the cerebrospinal fluid, which I won't show you now, and also in the brain of these patients. And this appears at least to be very much associated with the chronicity of major depression. So just bringing this through now to some sort of conclusion, the way certainly I'm beginning to think about treatment-resistant depression is we're seeing secondary changes in brain structure as a consequence of these chronic biochemical changes initiated by chronic low-grade inflammation. We can see from one of the early studies here of RAP that there's a correlation between depression, and particularly lifetime depression, and the synthesis of beta amyloid. So if you've had depression before developing Alzheimer's disease, the density of plaques and tangles is enormously increased. And that suggests indeed that in the very early stages of depression, one's getting an increase then in these neurotoxic compounds within the actual brain itself. And coming back to the points that were being made by Professor Ferrier, the cognitive deficits, actually the cognitive deficits can be seen very, very early on with early memory loss and so forth, suggesting that there is already, in the early stages of major depression, some sort of degenerative changes in the hippocampus and the hippocampal function, and possibly in the medial temporal lobe. This does appear to be associated with hypercortisolemia and is also associated with the increased presence of the ApoE4 allelic form in the blood. So these things do seem to be sort of coming together, and what interests me as a former biochemist is to look at the possible mechanisms. How and why do these pro-inflammatory cytokines activate the pathways leading to increased beta amyloid and neuronal damage? And in fact, if one looks at what happens with the changes following a chronic increase in interleukin-1, there's an increase in tau phosphorylation and neurofibrillary tangles, there's an increase in astrogliosis, there's a reduction in acetylcholine with cholinergic impairment, and indeed an increase in beta amyloid with neuronal damage. So one can see the consequences of long-term exposure of the brain to chronic low-grade inflammation. Similarly, the other pro-inflammatory cytokine, interleukin-6, also commonly is increased in patients with major depression and treatment-resistant depression. Again, one's got an enhanced effect, particularly upon beta amyloid synthesis and neuronal damage. And so, in summary, I think that in depression, we've got a whole number of factors which have been emphasized again by the previous speaker. The genetic and the epigenetic factors are clearly important, but as a consequence of depression, there's a number of pathways, neuronally damaging pathways, which are increased, leading to decreased neuronal repair, associated with the increased synthesis of and presence of pro-inflammatory cytokines, leading to chronic neuronal apoptosis and impaired function. And again, it can be argued that in later ages, in the later age of the patient with chronic major depression, and particularly with treatment-resistant depression, this is much more likely, therefore, to lead to neurodegenerative changes and dementia, of which, of course, Alzheimer's disease is the most common. And so, in conclusion, Mr. Chairman, what we're arguing is that from a biological point of view, that in treatment-resistant depression, yes, there's a dysfunctional hypothalamic, pituitary, and immune axes, both of which play a very important part. There seems to be a genetic loading, a genetic predisposition to this. Chronic inflammation seems to contribute to the changes, the neurodegenerative changes in major depression, and they become more enhanced in patients with treatment-resistant depression. One of the reasons why these changes occur is that the pro-inflammatory cytokines actually activate a whole number of neurotoxic pathways within the brain, which then contribute to lack of brain repair and indeed brain damage. So one possibility is that future treatment of depression, and possibly also new approaches to treatment-resistant depression, may involve looking much more carefully at the endocrine immune axis rather than just concentrating, as has always occurred hitherto, on one or two primary aimings within the brain, which don't appear to, as we've heard, to offer the answers to all of our problems at the present time. With that, Mr. Chairman, thank you very much. I will shut up.